Do you have a video on how to interpret Bayesian analysis?
I do not.
Work on that one for me, okay? Please.
This is the Rounds Table. All right, welcome back, Rounds Table listeners. We have a Fralick versus Fralick. Fralick and Fralick episode, not a solo episode, as has been the norm recently. No, it's back to the good old days where John has one article, I have another article. John, what article do you have up first?
Yeah, first up, Spironolactone versus placebo in patients undergoing maintenance dialysis, an international parallel group randomized control trial, the ACHIEVE trial. This was by Walsh et al., published in The Lancet, August 2025.
Yeah, I definitely missed this one when it was published, so happy you're discussing it today. What was the research question?
So the question here was, does spironolactone reduce the risk of heart failure and cardiovascular death in patients on dialysis?
All right, and why did it catch your eye?
Well, patients with CKD on dialysis are at increased risk for cardiovascular complications and death. Aldosterone is elevated in patients with renal failure and may contribute to the risk of heart failure and sudden death. We know spironolactone, a mineralocorticoid receptor antagonist, plays a role in reducing heart failure events and cardiovascular death in patients with congestive heart failure and in patients with CKD, but those not on dialysis. So the authors here set out to study if spironolactone is safe and effective in patients on dialysis from CKD.
Yeah, it makes sense. Every time I'm on service, and I think probably same as you, we have multiple patients who have end-stage renal disease, many of whom are on dialysis. It's such a high-risk patient population, so if there's anything that can improve outcomes, why not? And, our beloved SGLT2 inhibitors, you at least cannot start those if somebody is on dialysis. Anyway, what were the methods?
Yeah, it's kind of like, what is the goal-directed medical therapy for those on dialysis? Well, so the methods here. This was an investigator-initiated international parallel group randomized control trial. Patients were enrolled in 143 dialysis centers in 12 countries. For the patient population, patients were aged 45 or older, or 18 and older if there was a history of diabetes, and patients had to have been on maintenance dialysis for at least 3 months. There were a few exclusion criteria. If your potassium was 5.8 or more within 6 weeks of enrollment, if you were on a mineralocorticoid receptor antagonist and unable to withdraw from it, if you had an allergy to spironolactone, if you were pregnant, if you were scheduled for a renal transplant, or if life expectancy was less than 6 months. So for the intervention, there was an initial run-in phase for all participants for 7 weeks. And this is where everyone got spironolactone 25 milligrams and potassium levels were monitored. If your serum potassium was less than 6, you were then included in the formal study and you were randomized 1-to-1 to either spironolactone 25 milligrams once daily or placebo. And then patients were followed at 3 and 6 months and then every 6 months thereafter. For the primary outcome, it was a composite of cardiovascular death or hospitalization from heart failure. There were a bunch of secondary outcomes, including the components of the primary, as well as total severe hyperkalemia and a few others. And then as an aside, there was noted to be concerns of data fraud at 4 specific sites in India, and the decision was made to remove those participants from the trial.
Gotcha. So who was included apart from, of course, those 4 specific sites in India?
Yeah, other than those 4, so from September 2017 to October 2024, 3,689 patients were screened and 3,565 were included in the run-in phase. Ultimately, 2,538 were randomized between the two groups. 36.7% were female. The mean age was 62. About 42% were on dialysis for diabetic nephropathy, 26% for hypertensive or ischemic nephropathy. The median time on dialysis was 2 years, and the majority, or 84%, were on hemodialysis specifically.
Okay, that's a pretty impressive drop from the 3,500 in the run-in to the 2,500 who were eventually randomized. And I guess that goes to show that spironolactone sure does cause hyperkalemia.
I know that, this was a selected group because they wanted to make sure that patients were going to be able to tolerate the spironolactone.
Yeah, which makes sense. Of course, in real life, there aren't run-in phases. You just start drugs or don't start drugs. But anyway, what did they find?
So the trial was stopped early after an interim analysis indicated futility. The primary event, which was cardiovascular death or hospitalization due to heart failure, occurred in 258 participants in the spironolactone group, and this corresponded to 10.46 events per 100 participant years, compared with 276 in the placebo group, or 11.33 events per 100 participant years. The hazard ratio was 0.92 with confidence intervals ranging from 0.78 to 1.09. Severe hyperkalemia was more common in the spironolactone group at 4.97 events per 100 patient years compared with 3.23 per 100 patient years in the placebo group.
Gotcha. Yeah. So really it's like the event rate of that primary outcome is 10.5 per 100 patient years if you got spironolactone versus 11.3 per 100 patient years in the placebo group. So clearly no difference, but an increased risk of hyperkalemia, which should surprise no one. What were the limitations of this study?
I mean, overall, this was a really well-designed multi-center international trial. They did comment that the trial was designed to detect a large treatment effect of about 25%. And so whether or not spironolactone may have a more modest benefit in patients with dialysis is not known, but that's probably a moot point given the risk for hyperkalemia.
Yeah, it's incredibly impressive to pull off a multi-thousand patient randomized trial. You know, they spent almost a decade running this trial. Like, kudos to the authors. It's extremely hard to pull this off. Very easy to criticize a trial, but extremely hard to pull it off. But there's no planet where I would be starting patients on spironolactone if they're on dialysis based on these results. That's my take-home point. What's your take-home point?
Yeah, the take-home is the same. Spironolactone did not reduce the risk of death from cardiovascular causes or hospitalization due to heart failure in patients with CKD on dialysis.
Okay, and practice changing?
I agree with you. Don't start spironolactone if your patient's on dialysis.
Yeah, and there is one time where I have started it, of course, in concert with nephrology, and it was a patient who had, highly resistant high blood pressure, despite you name the agent, they were on it. In that case, we did start them on spironolactone, and they were managed closely, and the dialysis knobs were finely tuned so that the patient wouldn't have hyperkalemia. Definitely helped with her high blood pressure. This study, of course, wasn't for high blood pressure. It was, can it reduce the hard outcome of death from cardiovascular causes, heart failure admissions? And clearly the answer is no. All right, one down, one to go. This study is entitled Prophylactic Antibiotics for Upper GI Bleed in Patients with Cirrhosis, a systematic review and meta-analysis published in August 2025 in JAMA Internal Medicine.
All right, what was the research question here?
To determine whether current evidence continues to support the recommended 5 to 7 days of antibiotic prophylaxis in patients with cirrhosis and upper GI bleed.
And we don't cover a lot of systematic reviews and meta-analyses, but I think this is a pretty important question. So why did you think this was important?
Yeah, we don't cover any. I sort of felt like let's do RCTs or bust. And maybe that was wrong. Maybe it's like RCTs or systematic reviews and meta-analyses. So why is this important? Very old data suggests that 60% of variceal bleeds are complicated by bacterial infections. But these data are so old, I'm not even going to timestamp them. Guidelines do recommend antibiotic prophylaxis in patients with cirrhosis and acute upper GI bleed, grade 1A evidence, but actually based on many small single-center trials. The recommendation used to be for a fluoroquinolone. Now that's moved towards third-generation cephalosporin for 5 to 7 days. But antibiotics have risks. So, these authors appropriately said, well, let's revisit the data here and see if it truly holds up.
Yeah, okay, great. So how did they do this study?
So this was a systematic review and meta-analysis. The included studies really had to be a randomized trial. So they excluded observational studies. And the randomized trial had to compare antibiotics to no antibiotics or shorter versus longer duration. So, the intervention of antibiotics versus no antibiotics, that kind of makes sense. And then a separate analysis for shorter versus longer courses. The main outcome was all-cause mortality. They had a number of secondary outcomes and subgroup analyses and sensitivity analyses. The stats were complex. They were Bayesian statistics, so we'll leave it at that.
Yeah, Bayesian statistics. Don't even bother explaining that to me because I don't understand. What did the patients look like?
So they screened 600 some odd articles, 14 were included. All of the included trials were small. They almost universally had less than 100 patients. Some were a little bit bigger. There were 12 trials that compared any antibiotics, could have ranged from 1 to 10 days to no antibiotics. And there was 2 trials that compared shorter durations of antibiotics, 2 to 3 days, compared to longer durations of antibiotics, like 5 to 7 days. Most often the antibiotics were fluoroquinolones or third-generation cephalosporins. For the patient population, 74% were male. Most of the studies had an average age ranging between 40 to sort of mid-60s. 90% of patients had a variceal bleed. Some other quote-unquote table 1 characteristics for meta-analysis are, what was a risk of bias for these trials? And 8 of the included trials were at high risk of bias, which doesn't surprise me because when it's small and single center, and almost all of these were unblinded, that's at high risk of bias. The final table 1 characteristic is that most of these trials were from the 1990s. Nearly all of them were before 2010.
All right, so what did they find? Do antibiotics reduce all-cause mortality?
The short answer is it's Bayesian, so I'll give you a probability. The shorter answer is no, they probably don't, maybe not. This is Bayesian. So they looked for non-inferiority of shorter duration of antibiotics, and shorter durations were non-inferior for all-cause mortality, with a 97% of being non-inferior. The probability of non-inferiority when the trials were restricted to no prophylaxis versus prophylaxis, the probability fell to 89%. And then for shorter versus longer duration of third-generation cephalosporins, the probability of non-inferiority was closer to 98%. They also looked at the risk of bacterial infection. Shorter durations were actually inferior to longer durations for study-defined bacterial infection. A pretty impressive risk difference of like a 15% higher absolute risk difference, of course, with a credible interval. And the devil's a bit in the details because many of the definitions of bacterial infections are things we actually wouldn't really call a bacterial infection. So, for example, asymptomatic bacteria, we would no longer call that an infection. A couple of the other outcomes, the probability of non-inferiority was higher in the shorter versus longer duration of third-generation cephalosporins compared to the no prophylaxis versus prophylaxis studies. There are a few other data points, but I think I'll probably leave it at that for now.
Okay. So what are some limitations here?
So some of the limitations, it's that each of these trials was small, and many of these trials were biased. So with a meta-analysis, yes, you can compute an overall probability of X, Y, or Z, but that overall probability is only as good as the underlying studies. And many of these studies were so small at such high risk of bias, we should just sort of question the final results regardless of what the posterior probability is. That's probably the biggest limitation here. I also think as clinicians, there's still a lack of familiarity with interpreting the results of a Bayesian analysis. That's not exactly the researcher's problem. Maybe that's like the clinician's problem.
Yeah, do you have a video on how to interpret Bayesian analysis?
I do not.
Work on that one for me, okay, please. All right, so what's the take home here?
So I think the biggest take home here is that if you are prescribing 5 to 7 days of antibiotics for this clinical scenario of cirrhosis, upper GI bleed, it's just important to realize that the data to support that it's improving mortality is so limited, and these studies are at such high risk of bias. So I think you should actually have a tremendous amount of uncertainty whether or not that is helping. And probably the take-home point is that we need a large, multi-center, blinded randomized trial so that we can figure out, is this actually going to be worth it? Is it actually going to improve heart outcomes?
Yeah, I think that's pretty fair. I mean, so is this practice changing? I guess probably we really need that study, but what's your interpretation?
I think if nothing else, this has probably taught me that 5 to 7 days of antibiotics for this clinical scenario, it's probably not right. It's definitely not based on good data. So this is definitely going to make me pause. And the next time I come across this clinical scenario, it won't be a 5 to 7 days of antibiotics. It'll probably be a much shorter course of antibiotics, partially from the results of this study, and also just from the fact that, the BALANCE trial has been out for a year and a half now. that randomized patients with a known bacterial bloodstream infection to 7 versus 14 days and showed it's non-inferior. So I don't think there's a planet where 5 to 7 days is needed here, because it's probably like, quote unquote, a prophylactic antibiotic.
All right, cool, man. I like it.
All right, that is it for the trials. Next, the good stuff. John, you're up first.
For the good stuff, we cannot predict the future, but we're sure hoping the Jays pull through the World Series. There was a nice article from the BBC profiling that one of Toronto Stars, Vladimir Guerrero Jr. We'll have the link in the show notes.
Yeah, so the listeners should know we're recording this October 28th. John, you made a similar statement when the Maple Leafs were still in the playoffs.
Don't say that.
And then by the time the episode came out, the Leafs were knocked out of the playoffs. So you might have just jinxed the Blue Jays' chances.
I take no responsibility for that.
Yeah, and for the astute listener, October 28th means LA is up 2-1, and last night's game ended at 3 a.m., which is a very, very late night. Okay, for me, I'm not going to talk about any baseball team that I care about. On our end, just trial files. We're now creating sort of one-page summaries for guideline documents. You'll see that hopefully released by the time this episode comes out. And the one-pager on the guideline has 4 sections. What's the grade 1A recommendations from this guideline? What's the grade 1B? What are some clinical pearls? And what are recommendations which were doctors should stop doing X, Y, or Z? So we hope it's a useful resource, always open to listener feedback.
Oh yeah, that sounds great. Man, gives me nightmares thinking back about like Royal College studying and going through some of the guidelines were so terrible. Like you couldn't figure out what mattered and what didn't. Now others are really well written, but that resource would have been very helpful.
Yeah, they do kind of suck, and they're so painful to read. I was at a conference a couple months ago, and we were discussing trial files there, and somebody came up to me. I won't name who it was, but she said, I wrote the guidelines for insert this condition, and she's like, I don't even want to read them. They're that painful. So I thought, oh man, thank you. I feel so heard and seen. All right, listeners, that's it. Stay well, and hopefully the Blue Jays won.
Talk to you later, Mike. The Rounds Table is hosted online at medicinepods.com, your one-stop source for comprehensive internal medicine education and evidence-based medicine resources. We can also be found on all of your favorite streaming services. You can also follow us on Instagram, LinkedIn, and X. And special thanks to our audio editor, Tamara Van Bakel.